What I'd like to talk about just briefly tonight is long-term complications of TTP. So we certainly know treatments have gotten better to treat the acute patient, to get them to recover, to not die from this acute disease. But what's becoming even more important are some of these long-term issues that you can see in survivors of TTP. And fortunately, we have many more survivors than we used to. This is a slide just to talk about how this disease happens and to try to say it in a simplified and straight way. What is supposed to be happening is this top panel up here. And this VWF is really the glue that sticks your platelets to your blood vessel wall when you have a defect, a cut, to form clots to stop bleeding. That's what's supposed to happen. And what this Adam TS13 protease that we always talk about is supposed to do is cut this up into normal size pieces. And these normal size pieces will clot where you're supposed to, but only where you're supposed to, and not in places where it's unwanted. When you have TTP, whether it's the acquired form of it, where you have antibodies that clear this protease, or you're born without it in the congenital form, you don't get the cleavage of this VWF. And then what can happen is spontaneously clots form in the smallest blood vessels. And that's really what TTP is. There are low platelets, and sometimes people see some bleeding issues, but this is really a clotting disorder, and that really has to be remembered. Many of you have obviously been through plasma exchange therapy, but we'll just talk briefly and simply about what it does. And as you can see, as again, many of you know, this is a machine that can separate the different parts of the blood. And what we do in TTP is remove the plasma, or the liquid part of the blood that has the antibodies that are causing the problem in acquired TTP patients. And we add back the donor plasma. The donor plasma has this Adam TS13 in it, but it also does not have the antibodies. You need a central line for this, again, as many of you know, and as a life-saving treatment as it is, there can be complications with this related to the lines, infections, clotting, and reactions to the plasma itself. So it's this plasma exchange therapy with steroids and rituximab that help to decrease the production of the antibodies. So we're removing it and blocking the production. This slide seems a little complicated, but I'll slow it down so it makes sense, because I think this is an important point. We've talked about this, researchers and clinicians talk about this second hit hypothesis. And simply put, what this means is just because you have low Adam TS13 activity doesn't mean you automatically get TTP. This was first found in mice, and mice were bred not to have this Adam TS13. And it was hoped that they would develop a TTP-like disease so it could be studied in the lab. But it didn't do that. You had to add other things, and the specifics aren't important, but you had to trigger them. You had to push them into a TTP episode. So they're sort of set up for the disease by having this low Adam TS13 activity, but they have to be pushed, triggered, or this second hit to develop the disease. We see this in people who recover from TTP, but still may not have recovered the Adam TS13 activity. They might be at risk for relapse, but they don't automatically do that. And if you don't believe me, you can look at congenital TTP and women who are born without the Adam TS13 protease, but may not get in trouble until their first pregnancy in their 20s. So their entire life, they didn't have the Adam TS13A, but they didn't get that second hit, if you will. This slide looks a little complicated, but we'll just simplify it. And this is looking at people's Adam TS13 activity in remission. So when they're clear of their acute episode and they have labs tested in the outpatient clinic. And one group, Dr. Pavani, Flora Pavani from Italy, measured the Adam TS13 activity more than 30 days after the last plasma exchange, but before they ever had a relapse. And what they found is if your activity was less than 10%, about a 3 times increased risk of getting a relapse. And that risk goes up a little higher if you have the low Adam TS and you have the antibody. If you look on this right side, this is another way of looking at the same thing. And these data are about 10 years old from our group. But what we did was follow people every 3 months and measure their ADAM TS13 activity. And what this measures is the ADAM TS13 activity and the probability of relapse. So this is everybody. And the lower the ADAM TS13 activity was in remission, the greater the risk of relapse in the following 3 months. But the risk isn't terribly high. It's just approaching 10% over the next 3 months. But what you can see in this bottom panel, if you separate out by age, the younger you are, the greater that risk of relapse is. So the youngest patients, the 20 and 30-year-olds, have about a 30 to 50% chance of a relapse in just the next 3 months if their ADAM TS13 activity is low. And that's why we talk about treatments to improve that in remission to prevent relapse. Now, what I'd like to talk about more, in addition to the living longer, which we obviously want for everybody with TTP, we want people to live better with TTP. And again, one thing we've learned is that as more and more people survive this TTP episode, there are things that can happen long term. A lot of this work was really pioneered by Dee Terrell and Dr. George, Sarah Vesely at Oklahoma University. And it doesn't seem that long ago that this was published, but it's almost 10 years ago now, where what they looked at was the survival after your diagnosis of TTP. And here in this bottom line are the expected mortality rates in US and Oklahoma. And this line here is the patients who had a prior history of TTP. So you start to see as you get into the 10 to 15 years after the diagnosis, about a 25 to 30% chance of dying. So much greater than would be expected in someone who didn't have TTP. And that was the first clue that there may be something different long-term in patients. And indeed, if you take care of patients, I'm preaching to the choir here with the physicians who take care of these people, and especially the patients who deal with these complications, is there are things that people will say they're just not quite right. And a lot of them are things like short-term memory, forgetting where you put your keys, maybe asking the same question of your partner or your spouse twice. Headaches can happen, mood disorders, anxiety disorders, sort of behavioral changes, and cardiovascular disease is something we're going to talk about. These aren't terribly obvious, and to the person just meeting you for the first time, they might not notice the difference. But to the patient and to their families and caregivers, they certainly notice a difference. As much as we know about TTP, we don't even know how common these complications are. We're not even certain why they happen. And you really need to know why they happen to try to be able to prevent them. Some of the first work done in this area, again, was from the Oklahoma group. And what they did was called neurocognitive testing. So it's really just sort of, if you think about it, as functional tests of your brain, just seeing how your brain is working. And they tested a lot of different areas, and you can develop different tests to study different areas of your brain. I should mention one of the important things is we understand these complications can happen, but you've got to find ways to measure them in the clinic. An experienced physician can pick them up, but you have to be able to measure them, quantify them, to really understand, to really measure in a large group of patients how common they are and how they might be changing over time. But in this work done by the Oklahoma group, they found patients with a prior history of TTP function significantly worse on 4 domains, especially what's called complex attention or concentration skills. So kind of being able to focus on the right now and what's going on, the information processing speed, rapid language generation, and memorization. And really, these are all sort of short-term related issues, and I'll show you in more concrete terms on the next slide. So 21 of 24 patients, almost 90%, performed below expectations on at least one of these domains. What was also interesting, it wasn't very clear why these happened. Age, what did not clearly predict it. Severity of TTP, number of episodes, didn't seem to predict it. So in some follow-up work that we did with Dr. Scully from the United Kingdom, is looked at patients, again, in remission of TTP, but used a test that's easier to do in the clinic and very reproducible. And this was a test called a cogstate test. And it's a test that's thought to be language, intellect, independent. And it's really just the patients were sat in front of a laptop and there were cards that turned over, playing cards. So most people know what playing cards look like. And there's different questions
Somehow I got in.
on the right here. The detection task, identification task, the one back memory, and one card learning. And these are all measured here.
All right, I'll watch and I'll call you later.
And the lower you are on this scale, the more severely affected you are. And the red were the TTP patients. And something that we can all relate to here in the light blue is a blood alcohol content of 0.08%. So people who were legally drunk, how they functioned, people with depression, and people with dementia. So again, this task was very simple. They were shown in the first test, the detection, they were just asked a question, yes or no, has the card turned over? The second one, is the card red? So relatively simple. One back memory. So does this card match exactly the one before it? And then the one card learning was, have you seen this card before? And you can see the one they've performed the worst on, worse than drunk patients and patients with depression, is this one card learning. And it's really consistent with what we saw in the Oklahoma group. It's the short-term memory that seems to be problematic for some patients after they recover from TTP. So this is 10 years old, but it's still one of the first attempts to really reliably and easily measure this in the clinic, so you can do this on a regular basis. Another symptom that has been recognized in patients, and my fellow at the time, Jennifer Saltz, did this research study with me based upon the observation in the clinic that our patients with TTP were complaining of headaches a lot more than other patients were in the clinic. And it led us to do this very simple and straightforward study, which was just 6 questions, this HIT6 survey. It quite honestly took longer to consent them for the study than to do the study. It was just 6 questions and it was done. And what this survey does is sort of measures numerically how headaches are affecting a TTP patient's life. So normal is thought to be 51.7 in this group. So 50 to 55, headaches are having some impact. 56 to 59, a substantial impact on the ability to function. And 60 or more, headaches are severely impacting the patient's ability to function in everyday life. And we studied patients with TTP as well as AHUS, which is a similar disorder in that they both get small clots in the smallest vessels, but how they occur is a little bit different. But you can see the patients with AHUS really had a normal HIT6 score, but patients with TTP had close to 60. So they were on average functioning in the range of the severely impacted patients. You try to look at different features of the patients to understand why it's happening. And we tried to look at when they took their survey, how close were they to their last episode? So everybody had to be at least 3 months away from the last TTP episode, so you can clear out what is related to the acute episode. But as you can see, the majority of the patients and their scores were greater than 2 years from their last episode. And the highest mean score, so it's 69, way above that 60 where they're markedly impacted, occurred in patients whose last episode was at least a year previously. You can see the same thing. You would expect with multiple relapses, you would have more problems with the headaches, but you certainly don't see that. And 7 patients who had 1 episode really scored about the same as patients who had 3 or more episodes of TTP. So you can see we're learning more and more of how to measure these things, but exactly how they happen, why they happen is still a bit elusive. Mood disorders and depression are also a significant issue. And patients screened with the survey tool, this again is work from the University of Oklahoma, 60% were positive at least once, with 30% roughly, 15 patients suggestive of major depression and referred to a psychiatrist. The 9 that had this psychiatric interview, 8 of 9 were diagnosed with a major depression. So it certainly tells you the seriousness of the issue, but also tells you the ability of these screening tests to pick this up. And as we finish up here, this is some work done by my fellow Dr. Sukumar and Dr. Chaturvedi from Johns Hopkins, looking at a similar issue. We found the same effect of a shortened survival long term. And you look at the reasons for it, there's certainly relapse. The orange is the Ohio State, Johns Hopkins, the blue is the Oklahoma patients. And relapse is certainly there. But what is striking is this cardiovascular mortality. This is strokes and heart attacks and vascular disease, suggesting this really is a significant issue for patients. So what's the future of TTP treatment? Certainly trying to prevent relapses. But I think what we really have to do as we have more and more survivors is to try to understand these complications better. How common they are, how do they occur, or why do they occur, and how can they be efficiently diagnosed and quickly by the average physician in the clinic? And more importantly, can they be prevented and at least prevent these long-term complications? Really, the model is TTP is a chronic disease that we're going to manage long-term in patients, just like heart disease and hypertension. So with that, I'll stop and give the screen back to Adam.